Dear colleagues, and thank you, Magnus, for a very nice presentation. I'm glad to be here today and discuss with you the surgery of the massive weight loss patient, because these patients, they need us, and we need to defend them, to defend their need for surgery. I've met many of these patients with massive weight loss who come afterwards, and they have not been told that the surgery that we perform is not given to them by society. So in many cases, actually they have told me that they would rather not have lost all the weight because they really hate the way they are today. So we need to defend them in the eye of the public, and we need to inform our politicians about our successes in the surgical field. So I've been asked to mention something about timing and markings and indications, so I will not go into the surgery that Magnus did so well. But as we know, in the massive weight loss patient, excess is most often circumferential. So we need a circumferential abdominoplasty if we need to treat the total lower truncal part. Well, most of this surgery we've been doing for a long time. We've been doing aesthetical abdominoplasty since the mid-1920s, moving the umbilicus. Well, in the 60s and the 70s, Pitangui brought advances in the field, and Lockwood in the early 90s, he brought a more anatomical aspect to the surgery. And I will dwell with this just for a short while, because anatomy of the fat is important when we judge where we should plan our markings in these patients. So this is a funny looking picture, only showing the superficial part of the fat in the abdomen from when I worked with the CF lab. As we know, the Scarpa's fascia divide our fat in two layers, and in our thin patients they are of similar thickness, but with increasing BMI the superficial layer really gets more thick, and it also gets much more hard, and that is due to the vertical structures in the fat. And this is important because it makes our marks or hooks in the abdomen. So we actually have zones of adherence where the fat is much more stronger to the underlying surface, and this we find especially in the inframammary, the inguinal, suprapubic, and also between the hip and the lateral thigh. So for instance, the suprapubic zone of adherence is what makes the hanging of the pubic region. If we want to treat the lateral thigh, we need to dissect, or actually the abdomen and the legs. In women, making a high bikini scar because that improves the waist and also prolongs the legs. And then the liposuction marks, especially in the epigastric and in the waistline to be for women. But be aware of, don't do too much liposuction in men because they should have more of a V-shaped thorax. So while doing this, it's a good time to discuss with your patient, as Magnus told us, have the patient also lift the skin and discuss scar positions, and also, of course, important patient expectations. And it should be an S mark in the back, as Magnus also mentioned. And that is actually because you have most excess in the area close to the posterior axillary line. So it should be like that. And then the scar, more heart-shaped in a woman. Maybe this woman is a little bit high, but she's also just 6 weeks after surgery, so it will come down a little bit. And in men, as I would describe it, more an eagle wing position of the scar. Warn the patients about the upper rolls. This patient need an upper body lift in order to get rid of those. And then I think it's good to keep the liposuction to do a final add-up when you're finished with your open surgery, and also you can, with the liposuction, really loosen up zones of adherence, hooks that come visual when you tighten the skin. So important when you're doing your markings, be aware of fat deposition regions, and they differ in men and women. Talk to your patient about your musculoskeletal foundation, because these people, they have so much skin, so they are not aware of this. And of course, the foundation is very important to point out, because it has an impact on the overall appearance and the final result. And maybe most important to us, the quality and the characteristic of the skin fat envelope, the thickness, and also the components, the vertical components that makes part of this material thick. So how much you can pull is a very effective way of judging your final result. So the more pull, the better result. Indications, thorough medical history in these patients. We should really select them well. Of course, highlight diabetes, smoking, connective tissue disorders, cardiovascular disease, high blood pressure, common among those patients, and high BMI being a risk factor. Ali presented that almost 100% of his patients with BMI over 35 had some complication. Abdominal scar affecting either a circulation as the subcostal, or a midline scar that makes your flap less mobile. Evaluate with your patient the intra-abdominal content. This is considerable influence on the final cosmetic result. In some cases, you need a net to correct this. Indications, psychiatric stability also. These patients often have a lifelong psychiatric history, and that will not end with the bariatric surgery, actually contrary to that in many cases. And also the surgery is really a life-changing thing to them. And it's a wish of recovery from it all, from the patients. They can also meet from family and friends that they lost a fellow sufferer, which can be hard to bear. And so obesity-associated depression may persist. This is a young, actually good-looking man who lost weight by himself, by no bariatric surgery, and has undergone a circumferential abdominal plasty. And he told me before going home to Småland for vacation that he really had a hard time doing that, because among his friends he was still called a fatso. So he'd lost 50 kilos, but he was still a fatso, and that was hard for him to bear. Nutritional habits. These patients should be on oral vitamins. If they're not, that could reflect poor follow-up or deficiencies. So anemia, iron, vitamin B, thiamine, albumin, calcium, magnesium deficiencies are common among those patients. And that is, of course, bad for recovery after surgery. It's not uncommon to find elevated liver functional tests. And it's also important to check their bowel habits, diarrhea that could lead to nutritional deficiencies, and also be a problem with wound contamination, of course. And timing is very important. Check the patient again, weight at consultation, and length of present weight. Method of achieving weight loss is important. Historical maximum and minimum weights, and false plateaus. I've been told by the bariatric surgeons that you can expect the maximum weight loss after gastric bypass to be 18 months, and after bandage 2 years. And then weight maintenance, and it should be at least 3 months, and I look for 6 months. And this should be without heroic efforts for the patients. I mean, it should not be unconventional diets or excessive exercise. Then you should actually delay the surgery. So to highlight this, I'm just going to give you a short case report. It's a man, age 28, who underwent straightforward circumferential abdominoplasty, but he just didn't stop bleeding. I reoperated him first and second post-op day, no obvious source of bleeding. He got blood, thrombocytes. I needed fibrin glue and even factor concentrates to have him stop bleeding. After surgery, he had a full coagulation investigation that was all negative, nothing was found. So what was his history? I knew that he had lost 50 kilos. I knew he'd lost it with no bariatric surgery, but I didn't know how. And it turned out that he had actually been walking 4 hours daily and ate almost nothing for 4 months, losing 50 kilos. So I looked in the literature. I spoke to friends in the US, specialists in the field, if they had similar reports and patients. And I think that we can learn from this that excessive weight loss, and especially in a very short time period, creates a very catabolic patient, and this gives liver damage that actually could be permanent. So they have a permanent protein deficiency, a low production of protein, so that affects the coagulation. So actually this is highlighted in the US now, so they don't let their patients lose the weight as quickly as they actually still do in Europe and in Sweden. But here I had to use TCL that I did, or fibrin glue. So I think that that's one thing that you should have at the clinic and be in your arsenal of treatment in these patients. I did a small randomized study, and I'm not going to go into depth with that at all, but showing that TCL could be useful for these abdominoplasties, and especially the circumferential abdominoplasties. And what it actually led to a good discussion about the difficulties with these patients in the PRS. Since the turn of the 21st century, there's been actually an explosive growth of bariatric surgery and acceptance, and even in Sweden. So new procedures, and not only anterior but circumferential abdominoplasties, is really on its way. And the patients know this and they ask for this, but not the public, and the politicians are not aware of the operations that we can do, and also are not aware of how long time this takes and how much planning and timing and indications that we really have to inform our patients about. So we should of course ask ourselves, should we do this? This is what the patient of mine told me just recently. He came back for a 6 months checkup. I removed 12 kilos on him at one time. He went home after 2 days and no problems, and he was just so happy. So yes, we should absolutely take care of these patients, and we should do it. I do think that our specialty are best fit to do that because of surgical, medical, and also psychiatric issues involved. So thank you.